Dear colleagues, I am Michel Comajda. I'm a heart failure specialist based in Paris. And during the next 5 minutes, I would like to discuss with you the gaps in heart failure guideline implementations and barriers to optimal heart failure care. This is my disclosure slide. And the first question I would like to address is whether we provide recommended heart failure medications to the right patients and at the right dosage. And unfortunately, the answer is no. This slide shows to you a survey made in the Netherlands, the Czech Heart Failure Registry, from 34 centers. And you can see first that there is a wide variation in the rate of prescription of recommended therapies from one center to the other. This is the top part of the slide. And if you look at the pie chart, you have a huge proportion of patients in red who are taking a low dose of ACE inhibitors, ARBs, or beta blockers, for instance. And this holds true also in other parts of the world. This is the CHAMP Heart Failure Registry coming from the United States. If you concentrate on the gray part of the bars, which is no medication at all, you can see that the substantial proportion of FREF patients who are eligible for ACE inhibitors, ARBs, ARNI, beta blockers, or MRAs are not receiving this drug. And there is a price to pay, which is shown here from the Biostat CHF registry. If you look at the red curves, which is no prescription of ACE inhibitors on the left-hand panel, no beta blocker on the right-hand panel, or those patients who take a low dose of each of these medications in green, there is obviously a higher mortality rate than in patients who receive the drug at a higher dosage. And indeed, we did a similar approach in the Qualify registry, which is a worldwide registry, including 33 countries, more than 6,000 ambulatory heart failure patients with FREF. And we built a score which takes not only into account the rate of prescription of heart failure classes in eligible patients, but also the dosage which was reached. And the higher the score, the better the adherence to guidelines. And you can see that both for heart failure deaths on the left-hand panel and heart failure hospitalization or cardiovascular deaths on the right-hand panel, there is a clear relationship between low dosage and low rate of prescription of heart failure medications and poor outcomes. Now, is the situation changing with time? And again, we have to say that the answer is no. Here again is shown the example of the CHAMP Heart Failure Registry. And now, if you look at the curves and the bars, should I say, with time, you can see that there is virtually no change on average in the dosage used for these 4 classes of heart failure medications. And in particular, the patients at 100% of the target recommended dose are only a minority. And this is true also in the Qualify registry. This is a study made by my colleague Martin Cowie, and we looked at the change in the dosage regarding ACE inhibitors and ARBs on this slide with time over 18 months. And you can see that on average, there is virtually no change in the dosage reached for each of these 2 medications. And the same holds true for beta blockers, MRAs, and ivabradine. So in summary, we do not change the medication and the dosage of heart failure medications with time. And this is true all over the place, because it has been observed both in the United States, in Europe, in Asia, and in Africa. And we have several explanations for this situation. The first one is related to physicians. Some physicians have a lack of knowledge and what the objectives of the treatment of heart failure should be. Sometimes you have different attitudes and perceptions of guidelines and their recommendations, and there are obviously some communication barriers. Other factors are directly in relationship with the patient situation because of the occurrence of side effects or contraindications to a given class, the comorbidity, which makes management of heart failure patients, particularly in the elderly, complex, self-care capabilities, and once again, education of patients and understanding of the objectives of the treatment. There are guideline factors. Usually our guidelines are lengthy and physicians need pocket guidelines in order to implement what we are recommending. And finally, there are obviously logistical and financial factors because of the cost of some medications or access to healthcare resources, which can be a major issue in some areas of the world, not to speak of the inadequate patient journey downstream of heart failure hospitalization. Is the situation likely to change? Maybe, because the latest guidelines released by the European Society of Cardiology have made a major change in what we now recommend. If you look at the left part of the slide, in 2016, we had a lengthy stepwise approach with first initiation of ACE inhibitors and beta blockers, a titrate, then introduce MRAs, and then the two options, which were ARNI or ivabradine. In 2022, there has been a major simplification. Now there is a block of 4 classes of medications which are recommended in all patients except in those who have side effects or contraindication. I mean, ACE inhibitors or ARNI, beta blockers, MRAs, and SGLT2 inhibitors. But these new guidelines also highlight the need to consider a personalized approach based on the individual profile of each patient. And this is a place to consider in particular ivabradine in patients who keep a high heart rate despite maximally tolerated beta blocker dose. And this has been highlighted by Giuseppe Rosano and colleagues in this position paper, and it highlights the need to consider all the factors which make an individual patient an individual case, if I may say so, taking into account the heart rate, the existence or absence of atrial fibrillation, renal function, blood pressure, and other comorbidities. So this is what I wanted to summarize. There are many factors which can explain the gap in implementation of guidelines, and we still need to work hard in order to improve the situation. Thank you for your attention.